Hour as well. Thanks, Sydney. We are moving very fast and furious this hour. We have so many good topics to cover, and we have a couple of guest speakers, and so we're going to be super mindful of our time today so that everyone can learn the most from our guests. This is the team. We wanted to welcome Kelsey Keenan. We have a new co-chair for this program. And Kelsey has graciously offered to help, and so we're glad to have her. You'll probably see her around this year. She is a nurse, and she practices in Northern Colorado Medical Center, and so for any of our nurses involved in the program, there's programmatic questions about actually implementing the program on the floor in the hospital. Kelsey is an excellent resource for us, and so feel free to reach out if you have anything you'd like to ask her. Again, we're going to keep moving. Introduce yourself in the chat. Feel free to share what facility you're from, maybe what your role is, if you feel comfortable doing that. And you get extra bonus points if you can share a win. So anything your hospital is doing right around cesarean reduction, anything that you can celebrate that happened over the past month, any progress that your team has made in implementing SOAR at your site, we would love to hear what's working well for you. So feel free to use the chat. This is our agenda for today. Like I said, we're going to move really quickly. We have two guest speakers. One is from Sterling Medical Center. They're going to share what's happening on the ground at Sterling and how the program is going at their hospital. We're going to cover just a couple quick data points. We have Jerry Walsh from Denver Health, who's going to come and share about intermittent auscultation and how they're using it at Denver Health. We're also going to talk about how we can manage resistance to change, because we're in month 3 now of this program. And if you all haven't felt resistance, then you're probably not doing it right. And so we're going to talk about some ways that you might be able to manage some of the resistance you get when you're having new quality improvement initiatives to launch. And then finally, we're going to talk about our structure measure of the month, which is inclusive labor management huddles, and get a bit of information about what's going on at your hospitals if you're already doing those types of huddles and what's going well. So I'm quickly going to hand it over here to Rachel Lindgreen. Rachel, I'll let you go ahead and do your own introduction. I will stop sharing in case you have any slides. And if you don't have slides and you're just going to chat, you're welcome to do that as well.
Yeah, you can leave up that map. I think it's helpful for people to know. I don't have any slides, so.
Perfect.
My name is Rachel Griffith. As Amber mentioned, Rachel Lindgreen have it, sorry. And I am a family medicine OB physician in Sterling, Colorado. So I think it's good for context for people to see where it is. We are about an hour and a half from Denver, and our population is about 14,000, but we serve kind of the rest part of that, like northeastern corner of the state, essentially. We deliver about 300 babies here, so I think that's helpful for context in a year. We have been participating in SOAR since 2020 or 2021, I think. And we've been asked to share kind of like what has worked, because we have now been transitioned into like the graduate program, I guess you would say, where we are kind of like not required to submit data as often because we've kind of been doing so well. So I wanted to tell you a little bit about why I think we're successful, kind of what our process looks like, and then like let you know just in terms of like, even though we've graduated, what our team thinks of that information. So our process has been kind of easy to implement, which I think is a good thing for you guys to be talking about the resistance. We have not faced that, mostly because I think we have a lot of young family medicine trained physicians. We don't have like a high population of OBGYNs, and we don't have a lot of more experienced or old school, as you would say, providers. And I think that tends to lead a little bit towards like being a little bit more evidence-based, et cetera. We also have amazing nurses and administrative people who support our participation in the SOAR initiative, and have kind of like part of our metrics, even within Banner, are to monitor how many C-sections we're doing. And we share that information at our monthly meetings. So part of the way that our process kind of works is each patient who would fall into the criteria for filling out a SOAR checklist, that checklist is ultimately done by the provider, by the physician, often with the nurse present, who's helping to manage that patient, but we put it in the responsibility of the physician's hands. because it's really like them who are making the decision anyway. And I think a lot of our physicians like the checklist because it helps to kind of go through the step by step of like, does this patient really quote unquote qualify for that primary cesarean section? Then once that's done and kind of the patient has been taken a C-section, eventually the checklist, the physical checklist gets placed in the in a folder for a single nurse who has kind of taken on the project as our lead from the nursing standpoint to enter into REDCap. All of the nurses know who it is. And I think that like has simplified it as well for us to get our data in because it's like, it's just one person. Like I mentioned, we are only 300 babies per year. So we're not having like this system works for us because of our size. But I know that a lot of the participating hospitals also like are not delivering 300 babies a month. So it could be something that might be worth implementing in smaller facilities. She puts it into REDCap and then we get that information back from the SOAR team. As I mentioned though, on a monthly basis, we also have a perinatal OB meeting where all of our providers are expected to attend, including our resident physicians, where we have our anesthesia team, our WIS team, and our CMO and CNO present to go over these metrics. And we actually look at by name who is performing X number of C-sections over the course of the year. And I think like not in a way, there's never been anything punitive in that way because it's not appropriate, but I think it does help kind of keep everyone honest to what we're doing. The last thing I'll just share is that I just presented at our last, what we call perinatal meeting, that we had been sort of released from our monthly data collection, and resounding across the board, everyone wants to continue doing the checklists. Everyone wants to continue submitting data. Everyone wants to continue to see how we're doing. And so I think that is just a testament to the program itself of like, people are bought in. And if you can get the team to buy in, people do appreciate the feedback and the information. So.
Thank you. That was amazing to hear. We love to highlight our teams who made it to sustainability, just to show our teams who are new to the program that it's possible, right? It's possible to get to the point where that you've changed the culture on your unit and you've implemented best practices that really sort of in the long term impact your outcomes. So Rachel, thank you. I know you're hopping off shortly, but if you guys have questions, please put them in the chat, or if you have questions after the meeting, I'm sure that we would be happy to connect you with Rachel and her team to learn from any of the best practices that they've been able to do. Good to see you.
Thanks, guys.
All right, moving on. Just a quick touch point on data. You guys should have submitted your January and February data already. Gretchen has made your data dashboards. If you don't know what I'm talking about when I say data dashboard, please contact us because every hospital has an interactive dashboard with all of your SOAR data, and it's accessible to you and anyone on your team to help guide your QI efforts. This chart here shows you the leading indications for NTSV C-sections among our cohort. So this chart is actually from our 2023 data, but it shows you that non-reassuring fetal heart tones and labor dystocias by far are the leading indications for NTSV C-sections in the Colorado hospitals. And if we could address those two major issues, we would cover about 80% of the rise in C-section rates. And so I wanted to celebrate a win for the cohort. This chart is showing us that of the patients who are diagnosed with arrest of descent as the indication for the NTSV C-section, we have slowly increased those patients who are meeting the exact criteria for that. So this is a celebration. We're at our highest rate yet. And so what that tells us is that your teams are accurately diagnosing arrest of descent. And for the patients who didn't meet the criteria, it's less likely that they would end up in a C-section. And so congratulations for that. We'll look forward to continuing to see your data as we move forward. I'll quickly pass it over to Victoria.
Hey, everyone. So as part of this learning collaborative, we wanted to briefly revisit the exercise that we completed in February. So if you remember, we worked through the effort impact matrix, which is essentially a tool that you can use to chart different projects and ideas based off of their estimated impact and then the effort that might be required to complete them. So we looked through the Jamboards and collected some of what you had recorded across the different groups. So you'll see here some examples of quick wins, that you can implement hopefully quickly, that have high impact and require minimal effort, and then some bigger projects that might require more investment, but are ultimately very high impact. So we just wanted to display them here. And we really hope that you use the tool in the future to prioritize any change ideas or projects that you might have.
Thanks, Victoria. And if any of you guys would like to see the Jamboards that we did last month, tell us. We'd be happy to share them out if that would be a good tool for you guys to use. I am thrilled to welcome Jerry. Jerry, I'll let you do a full introduction of yourself, but she has very graciously agreed to join us and share what Denver Health is doing with intermittent auscultation and how that may or may not be impacting their NTSB C-section rates. So Jerry, I'll hand it over and I'll let you share your.
Great. Thank you so much for the opportunity to speak today, and I hope I can share some helpful information as quickly as possible. So I'm a midwife here at Denver Health. I've been here for 17 years, and for the last, I guess, 6 years now, been the associate chief, otherwise known as lead midwife for inpatient midwifery services. So let me just share my screen here. I have a very lengthy PowerPoint presentation to share with you that I'm not going to read. And happy to send that to the group to peruse as you find important for your groups. I do want to give credit to where it's due for this presentation. So Molly Cook, a nurse at Denver Health, Emily Buckley, our labor and delivery clinical nurse educator, very little myself, and then previously Eliza Burrell, who is one of the founders of the midwifery practice at Denver Health and intrepid barrier breaker and standard bearer for midwifery at Denver Health. So there's a couple of sort of, as Amber recommended, ideas that are probably most important to this group about implementing intermittent auscultation. So really this was, the seed was planted for this with the integration of nurse midwives into the inpatient labor and delivery unit, and that started back in 2005. Previous to that, there were some nurse midwives scattered about the our community-based health clinics and our OB screening room, which is our OB triage unit. But over a couple of years, we became fully integrated into the interpartum, postpartum OB triage unit, and have grew from 1 midwife to 40. So why that's been helpful is because this is, we've been able to be the subject matter experts in implementation of intermittent auscultation as a resource to the nurses, resource to physicians, other midwives, and had a voice at the table of how to implement this as a standard of care and write policies around this. So basically, there is lots of evidence to support the benefit of intermittent auscultation as a standard of care for low-risk pregnancies. And what I mean by low-risk pregnancies is essentially couplets that do not have risk factors for placental insufficiency. So those are the pregnancies where you're going to see hypoxia developing during labor and poor neonatal outcomes. So if you sort of like put that into the framework of who the inclusion criteria and exclusion criteria would be for both maternal indications and fetal indications, and then clinical pictures that develop during pregnancy, you'll find great data to support developing a policy around this. So there's a lot of consensus publications that support intermittent auscultation as the standard of care for low risk pregnancies. And I won't go through all of the trials and policy papers and statements on this. At the end of this presentation are multiple references for you to look at for that. But the bottom line is that this is very well supported in the literature from the inception of fetal evaluation in the 50s all the way through present day. And we know also in the same context that continuous fetal monitoring is problematic. It's also one of the most common interventions that's done during someone's obstetric course in the hospital. There are benefits as well, I will say, but the mainly problematic because it has a high false positive rate and is not, it does not have a high rate of reliability for interpretation, as we've all experienced, I'm sure, on a daily basis with those category 2 tracings. Some of the benefits is that this is non-invasive, so patients have much more freedom of movement. It's less costly. Nurses and providers can provide more labor support rather than fiddling with monitors and watching monitors and things like that. For patients who desire less intervention, less anesthesia, that supports this. Supports out of bed birth positions, alternative birth positions, because we're not constantly trying to make the monitor work out of bed. And then, of course, lower cesarean rates, which is the goal of this committee, right, with intermittent auscultation. So I won't go through all of the inclusion-exclusion criteria. I think one of the important ways that this has been successful at Denver Health is that from the beginning, it has been implemented as a standard of care. And what that means basically is it's not an opt-in. You have to opt out or meet exclusion criteria for intermittent auscultation to be discontinued. So the way that works here is that upon evaluation in the screening room or admission to labor and delivery, if they're a direct admission for things like induction of labor, there's a 20-minute monitor tracing that is evaluated for normal baseline and rhythm and moderate variability, and then absence of persistent variable decelerations. The other important thing to note about how we've made this successful and implemented this is that it's within the nursing scope to determine whether a couplet meets criteria for intermittent auscultation versus continuous fetal monitoring. So if the couplet meets criteria for intermittent auscultation after this initial evaluation with fetal monitoring, then the nurse can determine what next steps are and if they're meet criteria for switching to intermittent auscultation. And what I mean by that specifically is that it does not require a provider to sort of approve or sign off on the next course of care. So I think that's really important because it reduces the variability of provider sort of implementing their own bias and judgment about whether or not they sort of quote unquote believe in intermittent auscultation versus continuous fetal monitoring. And it also helps people get used to the idea. It's really scary, right? When the only thing you've been used to your whole career is interpreting continuous fetal monitoring, and how to get comfortable with not seeing the fetal heart rate tracing and not having a continuous evaluation of the fetus during the entire labor course. And that admittedly takes a lot of exposure and practice with intermittent auscultation to sort of buy into that. The other way that it's been successful at Denver Health is by continually reinforcing that this is standard of care and ongoing education and skills assessment with the nurses. And how that's done at Denver Health is, let me move to this slide, is the nurse educator and their team use a very similar slide set that represents a lot of information from A1 into their onboarding of new nurses, and then also is reevaluated and reinforced at the yearly skills or competency evaluation. The other thing that helped it be successful was dissemination of all of the references and information supporting and studies supporting this as an appropriate or reasonable way to assess fetal well-being. And that takes a lot of perseverance, persistence, bravery on the part of the nurses, midwives, and providers who are champions of this. And so grand rounds, multidisciplinary rounds, staff meetings, provider meetings, all the ways that individual departments and hospitals disseminate information, have conversations about policies and standard of care. And it's an ongoing conversation and an ongoing work that needs to happen for it to be successful. It's a big culture change for hospitals that have never used this. And it's really hard for people to get on board with this. If they've never seen intermittent auscultation in practice and seen how well babies do in the appropriate within the guidelines. So those are some of the ways that we've helped it be successful. Similar to what I was just saying, the barriers in the initial few years of rolling this out were that what I just said is people were very uncomfortable. This was also a group of providers and nurses who had never seen births out of bed, never seen water births, had little experience with continuous labor support. There wasn't a lot of attention paid yet to cesarean section rates. So that took a lot of perseverance from nursing leaders and midwives and the physician champions at the time of midwives becoming integrated into the OB service, the inpatient OB service at the time. So that took a lot of, that was a big culture change and took a lot of persistence. That's the sort of nuts and bolts of how it started, how we've made it successful, the barriers, and recommendations for how other hospitals to make it successful. So I'll leave that open to some questions.
While people are thinking of their questions, feel free to use the chat too. Jerry, I'm really glad that you pointed out that intermittent auscultation is a skill, right? And it needs to be taught, often for sure for new grads, and then often for nurses who are new to your hospital and maybe haven't worked at facilities that have used intermittent auscultation. Like, we can't take for granted that they're coming to your facility with this skill. I love that you guys have integrated it into your skills days, because it truly is a skill that needs to be developed.
Right, and if you take a look at this slide presentation more in depth, there is a description of actually how to do this. A1 has some great teaching and learning tools as well. There's not consensus on the interval of listening, or so the frequency or how long to listen and the timing of listening. So that can be up to individual departments or facilities to develop specific protocols around that. But there is good consensus that this is a reasonable way to support or to evaluate fetal well-being. So take a look throughout the slides, and there's some more specific details about special considerations with certain clinical pictures, as well as how exactly to do, how we teach and perform intermittent auscultation.
So we have 2 questions in the chat. Kelsey, we'll send out this slide deck afterwards that does include the inclusion-exclusion criteria. Well, it's exclusion criteria only. There's one other question, Jerry, if you feel comfortable answering. How does variability come into play with IA? How would you know if a baby has developed persistent minimal variability?
Yeah, great question. So there's two pieces of that. One is the initial assessment with the 20 minutes of monitoring establishes that the baby is well oxygenated because there's normal variability at the time of admission. And really data shows that that doesn't change for the most part if the clinical picture doesn't change and there isn't risk for uteroplacental insufficiency. So some of the exclusion criteria address why we don't look for variability. And maybe part of the answer to the question is that intermittent auscultation cannot evaluate variability, nor can it evaluate the timing of decelerations that are heard. So you cannot document that it's a variable deceleration or late deceleration. And in the slideshow, there's some more specific information about what to do if you hear those kind of things. But unless the clinical picture changes with the couplet, then you don't need to know variability. Now, variability, admittedly, is an excellent predictor of normal fetal oxygenation, but without risk factors for poor oxygenation, we don't need to know that. And that's what the studies bear out, is that without risk factors, we don't expect that to change.
Thanks, Jerry. Appreciate it. I will brag on Denver Health. Among our highest volume hospitals in the state, Denver Health has the lowest NTSB C-section rate. So congrats to their team. Thank you, both Jerry and Emily, for being on the call today and sharing your knowledge. If you guys are super interested in IA, not only are you welcome to reach out to the Denver Health team and continue to learn from what they've done, but we did an entire hour-long learning collaborative session last year on intermittent auscultation with Dr. Lisa Kane-Lowe, and that's recorded on our YouTube channel. We'll link it in the follow-up email to today's session. And so if you'd like to go even one level deeper than I allowed Jerry to do today, then you're welcome to view that session. Jerry, thanks. I appreciate it.
One last thing, I'm happy to share our policy or our clinical care guideline if that's of interest to the group.
Is anybody nodding or raising their hand? Let us know. Yes, okay, so nods. Thanks for offering, Jerry. Appreciate it. All right, let's keep on moving. Like I said, our afternoon is packed. Let's start to transition and talk about how we can manage resistance to change. Like I said, when I opened today, if you haven't already met resistance to leading a cesarean reduction program at your hospital, it's possible that you're not overturning all of the possible stones that you could be for quality improvement. I found these quotes today and I'm just laughing. I think especially the iPhone one, that there's no chance that the iPhone is going to get any significant market share. I think clearly there were some very intelligent people who were really wrong about change ideas, right? And so we have the telephone here, we have the car, the television. And so I think, if even the smartest people in the room with these technologies are sort of doubting the success of the changes that were being proposed, then surely those of us on the front lines at our hospitals are also going to meet similar types of doubt and resistance when we're proposing new ideas or new ways of doing things. And I'll pass it over to Victoria.
Yeah, I love that slide. I remember I was young, but I was also skeptical of the iPhone. And I think part of the reason, right, is that as humans, we're just resistant to change. It can be equal parts energizing and also really terrifying. And I think we all want change on some level, but actually changing is quite difficult and can be a really challenging process. Go to the next slide. Yeah, and I think more often than not, we don't resist change because we want to be subversive or disruptive necessarily, but it's more so because we don't fully understand what the change is, and maybe we experience some fear and doubt about what the change might be able to bring forward. So, as people who are leading change efforts, first of all, it's a really difficult position to be in, but it's also a really important opportunity to build connection in your team. And part of building that connection is really making an effort to understand where the resistance is coming from. Is it because your team doesn't understand the change? Is it because they've had previous negative experiences with change? I know I certainly have. Maybe it's because of resource limitations or a perceived increase to the workload that feels really untenable and unsustainable. So here, I think asking open-ended questions with humility, leading with curiosity, is really important, and being more inquisitive than directive, even though it can be a really frustrating process to have team members who might be actively resisting or in some cases even disparaging change. And then, yeah, just the key problem, right, is not necessarily the people, but more so the human behavior that we all can relate to in one way or another. Next slide, I'll pass back to you, Amber.
Thanks. So there's some predictable stages that teams often go through when they're implementing changes, and especially for the people who tend to resist change. And I would guess that you all have seen these stages happening at your hospital at some point as you're implementing new practices and protocols that are disruptive to the status quo at your hospitals. But I think in quality improvement, we know this, that resistance is actually a necessary component of change, right? If we're not sort of challenging what it is we're changing, why we're changing it, and how we know that this change is actually going to result in improvement, then we have the risk of wasting our time and energy, right? And so sometimes resistance offers a really great checkpoint for us to say, why is it that we're doing this? Can we explain it succinctly and clearly to our staff in a way that makes them less likely to resist it? And it's more likely then that you have something that's worth your time and worth your effort. I also want to note that the level of resistance is usually determined by the amount of disruption for the individual. We have seen this very clearly, most recently in our cohort, when we have talked about releasing provider and nurse and TSV C-section rates, right? That can be very disruptive to the individual. And there's been a lot of feelings around that on the unit and on the individual level. And so kind of one example about what that will look like. I'm going to share a quick video here on the next slide. I want to set it up to say that we are not supporters. We have no investments in this TV show whatsoever, but it is a hilarious clip to sort of outline how change can look if the team is not ready for change. And I would love for you to think about where you think in this cycle the team is after reviewing this clip. Let's see if I can get it going here.
We're not eating right now. We're having a meeting about teamwork. And, by the way, I do have some awesome new free uniforms.
This is not a beauty contest. Do we look like beauty contestants to you?
Hey, I'm putting lipstick on the pig, so...
You put lipstick what?
Yeah.
You can wear lipstick if you want to. This is not Barbie and Ken that you're playing with back here, okay? Quit trying to dress me up.
The only way that I would wear that if I was dead and you put that on me
That's
before
right,
you put
and
me in.
bury you.
You will wear these or I'll dock your pay.
I feel like if I put these clothes on, I'm gonna look like a vacuum cleaner salesman.
I'm not doing it. I'll tell you that right now.
I ain't asking permission.
Hey.
We doing it, all right?
We make
Uniforms.
duck calls. Quack, quack. Quack,
Put
quack.
your uniforms on, boys.
Does that shirt have a collar on it? I don't have a neck. That don't work.
Thanks for humoring me. I saw Dr. Veronica Gillespie-Bell use that clip once, and I was like, ugh, if that doesn't outline what it looks like to tell your team to do a SOAR labor dissociate checklist without setting it up as to like why we're using this checklist, what's our end goal with this checklist, what value does it bring to our patient care and or our unit, I imagine that you would have some similar type of resistance to this crew here trying to implement a new change.
We're not eating right now. We're having a meeting.
I won't make you listen
about
to it again. There we go. Pass it back to Victoria.
Yeah, so as you could probably notice in that clip, there really wasn't any clear vision cast. It was pretty directive. So the first part of planning for change is to also plan for resistance. And part of planning for resistance involves having a clear vision that you can communicate clearly to your team and also more broadly, right, within the organization or ecosystem that you're a part of. And you want the vision to be clear, like I said, brief, right, concise. You should be able to say it in 1 or 2 sentences. You want to be flexible, of course, and like adaptive, right, and dynamic, but also communicate stability. And then, yeah, Amber touched on this earlier, but, if we're not being challenged, then we're probably not doing change right. It's not real change unless we're feeling that it's helping us build new muscles and competencies and confidence in ourselves and our team. Being future oriented is super important. And then of course, being inspiring or motivational. And I would argue that those prior bullet points are inherently motivational and inspiring, but it can be a really important part of casting and communicating your vision. Amber, I think this is you.
Yeah, so our end goal here is just to tell you guys to expect change, and not only expect it, if you can plan ahead for that resistance that you're going to have, that's the best way. And so like Victoria said, if you can't communicate the goal of quality improvement clearly, then your team is going to be very hesitant to get behind you in efforts to change their behavior and their attitudes. And so when I say communicate clearly, what I mean is that can you communicate why your unit or your hospital needs change, why they need change right now, maybe even sort of outlining what's the extent of the change that you're expecting of your team, or the timeline of changes that they can expect over the coming 6 months, 12 months. And then having a plan for how their change is going to be measured, right? Like, how are you going to give them back information on the changes that they're making in a way that sort of lets them know my input here is valuable, the changes that I'm making are resulting in improvement. And if not, how can you answer to your team about how you're going to change your quality improvement efforts if you're not seeing the output that you would expect from that program?
Yeah. And then also, right, considering who are your stakeholders, right? Getting the team together, talking through what your biggest barriers are. And my personal favorite, like, what is the cost of poor quality of not changing, not just on patient outcomes, but also on workplace satisfaction, on team cohesion, right? This is a critical sort of cultural element too, within your teams. And rating change is hard. I think you should name it, right? We have to name that. Very explicitly. It's hard for all of us, not just people who are leading through it. So I think the more transparency we have about our own experiences with it, the better, right? We want to normalize that, yeah, this is a difficult thing and we're still going to do it. And that also, right, our jobs are so busy and difficult, but we're talking about reducing avoidable harm here. So another helpful element, I think, is to create urgency. And a great way to create urgency is to also like zoom out and talk about what's happening in the state, what's happening in the learning collaborative, right? Like, what is going on more broadly in the L&D community, and participating in this learning collaborative, and even bringing some of those challenges here to this space is a great way to try and motivate your teams, right? Also, the tools that we've touched on so far are, we hope that you use them. So the effort impact matrix is something that you can do with your teams, find those quick wins, celebrate those quick wins. I saw so many in the chat today. It was really cool to see the wins that you've done even in the last month, right? Like, please celebrate those, not just here, but with your teams. They're not little wins, even though they're quick. They're very big milestones, and you should be proud of them. And with that being said, we will move into a breakout room. Let's do 5 minutes with maybe 5 to 6 people, Sydney. Yeah, so we want to give you room to talk to each other, brainstorm about maybe your experiences with leading through change and resistance, and how you might prevent or react to common change barriers. Like, what is that process? What does it look like in the past? What might you do in the context of this program? And we'll just leave it open-ended for you all. We'll see you back here in 5.
I can hang back in the main room if anyone has issues or questions. And then people can feel free to join as they will.
Thanks. We don't have a ton of time to debrief, but I'd love for your team to maybe put 1 or 2 things you discussed in the chat, right? Either if you talked about kind of what are the common resistance barriers that you're encountering, or if you guys were able to brainstorm any ideas or what your teams have done to plan for or address resistance for implementation, I'd love to hear those things. And if you see someone commenting something that you resonate with, feel free to reach out to that person and either offer support or get guidance of your own on how you are managing change. So I hope that was useful. We will keep on going. We have like 10 minutes left. We want to use them wisely. We wanted to spend just a couple minutes talking about our structure measures. And by that, I mean, what are the sort of foundational cultural changes, policy changes, or practice changes that can support cesarean reductions efforts on your unit. And so you all fill out a quarterly survey for these measures just to let us know what stage of implementation is your hospital already doing these things? If they're not, are they planning to do them? Or if they've not even started or considered these things as possible structures to support cesarean reduction at your site. So these are the 5 key areas that we're looking at. If you aren't sure if your team filled out the survey for these measures for Q1, please reach out. We'd be happy to resend you the link so that you could fill it out again. We usually ask that one champion from your program does that. It's often the nurse leader. They tend to be a little bit closer to the work that's on the floor, but it can be either a data champion or a provider champion as well. Today, I wanted to call attention to the idea of implementing inclusive labor management huddles. And by that, we mean, is there a process by which your team involves the patient in discussions on labor management and or decision-making, especially prior to deciding to do a C-section? And I'm curious to know if you're already doing that, is it working well for your team? And if you're not already doing that, have you considered it and or would you be interested in hearing what other hospital teams are doing? And so that's what we mean by inclusive management huddles. We're actually going to do a poll here on the next slide. Let's see if I can get that going, just to get a temp check on how you guys are doing with it. I think one of the most interesting stats on this for me is that 80% of Sentinel events were due to communication errors. I think that's a fascinating statistic to know that, that many sort of either near misses or bad outcomes were due to just us not communicating well, either among our team members and or with the patient. And I think inclusive labor huddles could be a really interesting way to both mitigate that and for us to involve the patient in their care. We know that patients can sometimes be confused as to why they had a C-section, either in the moment or years later when they're reflecting on their clinical care that they had. And inclusive labor management huddles can be one way to sort of bring the patient into those conversations so that they're better understanding what's happening and the decisions that are being made during their care. So I don't know if you guys can see these results yet. We'll close the poll here in just a second. It looks, I think, for a majority of you, you're not doing what you would consider inclusive labor management huddles. So about 46% of you are saying no, 33% are saying yes, you do some sort of an inclusive labor management huddle, and some of you are saying not yet. So maybe that's in the plans for you. We, this year, are planning to develop just a general guideline for a labor management huddle. What are the types of information that you might want to do, cover during a labor management huddle? At what critical time periods during the labor course would a labor management huddle really come into play? And maybe hear what other hospitals are doing to implement this at their site. And so we will continue to talk about those things. I'll go back to that slide. These other structure measures, sort of asking again, what policies, procedures, practices do you guys have in place? Next month, we're going to talk about debriefs for patients who had an unexpected or a traumatic cesarean birth and what's happening at your hospitals for that, maybe what resources you need and what we as a collaborative can develop as a resource for all of us. I'll pass it over to Victoria.
All right. So we spoke about at the last Learning Collaborative that we're going to touch in on PDSA cycles every month. So it's sort of a standing agenda item. And let's see, we don't have too much time left, but I saw so many wins in the chat, as I said. So I would love if someone could share, could either unmute or drop it in the chat, a PDSA cycle that you tested between February and now, how it went. Or maybe it was just a change and you didn't name it a PDSA cycle, but It was just a change and you planned for it and you did it. And what happened? Yeah, chat is wide open. So you can always write there. I've seen some really interesting responses too from our recap rooms. And if there aren't any this time, we might, so we have a link where you can share out. We might start doing that to just make sure that we're touching in on IHI breakthrough model and really, using some of those change frameworks. The PDSI cycle is definitely one of the more powerful ones, right? It's sort of the engine of QI.
I'll share some that we've heard hospitals doing over the past couple of months. If this is you, feel free to raise your hand or add more detail. I know for sure one of our hospitals in April is getting ready to implement the labor clinical care checklist. And so it's a forthcoming PDSA cycle. Super excited to hear how that goes. We know that many of our hospitals just introduced the badge buddies, right? The sort of back of the badge stickers that we handed out at the SOAR forum. And using that as sort of a reminder to hospital staff, providers, and nurses, what are the clinical criteria for labor dystocias? Those are two that I can think of off the top of my head. Team, any others that you can remember from our one-on-one sessions? It's okay.
No, but those are really good examples. And just as a reminder, these can be really small, right? Actually, they're intended to be. So PDSI cycles don't have to be a big project plan, that high impact, high effort quadrant, right? That's really not. The PDSI cycles live in a high impact, sort of low effort. They can be really small iterative changes that you're just testing out. So if you haven't had a coaching session with us, we'll definitely hone in on this with you and really help you think through what small changes you can begin implementing and testing. Oh, I see some in the chat. Awesome. Someone says sharing NTSB rates of RNs. Love it. Starting next Wednesday with charge nurses. That's awesome. Yeah, and some people have a plan and haven't gotten started yet until next month, but that's also great, right? Looking to the future and seeing, thinking towards what is possible and what you might be able to test out in the coming months.
I'm not looking at the chat, but whatever team that shared that they're starting with charge nurses for nurse rates, what a brilliant idea, right? To sort of like show some courage among the leadership on your unit, right? To say like, hey, we're willing to do this as well, even if it isn't public right away, right? The charge nurses are examining their own rates and seeing what changes they can make in their clinical care. I love that idea.
And Kelsey's is about starting a SOAR committee. So it's not the only RN involved. Love it.
Absolutely. Highly recommend not being the only RN involved. We wanted to give you a snapshot of what's coming next month. We're going to talk about how it is that you can pilot changes. So if we put you on the spot and you're like, I don't know what you mean by PDSA cycles, we're going to go into it a little more detailed next month about what do we mean about piloting changes, trying new things, and making changes at your site. We also have invited the Arkansas Perinatal Quality Group to share some wins that they've had with their cesarean reduction program. I think it's always valuable for us to learn from other states what's going well and what things that they're trying. And then we're also going to have a hospital team share out. I think Good Sam is scheduled to share out next month and tell us how they're doing and what changes they're making. We also, in the early stages of planning a labor support training that we are going to host this year. And so we're planning to host several offerings for that. And so two probably in the Denver metro area, one out in the mountain communities, and then one in northern Colorado. And so in the coming months, we'll be sharing more information about how many seats are available, maybe what type of staff or providers you would want to send to those trainings. It will be a free training that's available. It's not spinning babies, but it will cover a lot of the same principles of labor management and labor support, position changes, and great ideas, particularly about how we can manage labor dystocias. And so get excited about it. We'll tell you as soon as we get those dates on the calendar and give more information in the months to come. This is your to-do list before you come back next month. So I would love for you to schedule your Q2 coaching session with our team if you haven't already. The earlier you get it on the calendar, the more dates are available to you. We would love for you to share your data with your team. And so if you, again, don't know what I'm talking about with your data or your data dashboards, my question to you is, have you seen our amazing data dashboards that Gretchen creates for us? If you have not seen your data dashboard, reach out and we will make sure that you have a link to it and that you can sign in and see your own data and share it back to your teams. And then we encourage you to continue submitting your monthly data. Again, we get your NTSB C-section rates from the Department of Public Health, but the more detailed quality improvement data, like how are you using your labor discharge checklist? What are the leading indications for C-sections at your site? Those are things that we collect from the clinical care checklists that you all, many of you are already using and some of you are planning to use in the coming month. That information on the clinical care checklists is really valuable data that we're asking your team to submit back to us on a monthly basis. And if you haven't figured out the team member who's in charge of the data, now's a good time to do that. If you don't have anybody on your team trained to handle the data for this program or to submit it, we'd be happy to schedule a session with them to train them or to remind them how to submit data to us so that we can really give you more tailored help for what your site needs for C-section improvement. Our next session is on the 24th. Mark your calendars. It's 12 to 1 as always. Our sessions are always recorded. You're welcome to visit our YouTube channel if you guys have any sessions that you missed or if you're not able to make it to the April session. And I think that's where we leave you. Our team will be on the call for the next few minutes. And so if you want to stay on, if you have any questions, concerns, feel free to continue using the chat. It was so great to have your time over the lunch hour, guys. We really appreciate you spending the lunch with us and sharing your knowledge and being willing to make change and deal with resistance along the way.